Okay, good afternoon. Welcome to the Thurston County Board of Health meeting for this Tuesday, December 13th, 2022. It's 4:30 p.m. My name is Ty Minter, Chair of the Board. To my right is Maria Williams, our Vice Chair. We also have board members Gary Edwards, Carolina Mejia, Robin Vasquez, Dr. Beth Harvey. Board member Nelson may join us late, but is excused for this meeting. We have the County Manager, Miro Chavez, Assistant County Manager, Robin Campbell. We have Director of Public Health and Social Services, Kurt Harden, Clerk of the Board, Jamie Caldwell, and Dr. Dimiana Abdulmalik, our County Health Officer. We have a proposed agenda. Is there a motion regarding approval of the agenda?
I would move to approve this agenda this evening.
Second.
Been moved and seconded to approve today's agenda. Any discussion? Hearing none, I'll call for the vote.
Yes. Could I?
Yeah.
I would just like to say this evening, as we move into public testimony,
Yep.
that we have people, we have new board members, and we have people in the audience that may be testifying. And oftentimes I get asked, well, nobody seemed to care, or they weren't too interested, and I would just like to make sure that all parties involved know that we are very interested, but we don't have dialogue or interaction at the time of testimony, because we would just never get done if that took place. So I just like to point that out to folks, that we all do care very much about what is going on in our community. And once in a while, it looks like, well, we're just sitting there like a bump on the log listening, or making notes. So just like to have people know that. So that's my only comment, sir.
No, I appreciate that. I was going to make the same point, because there are boards where they do have direct comment from board members to public comment, but we don't, and so it's good for you guys to understand that. Excellent. So I've got a motion and a second for approval of today's agenda. Call for the vote.
Board Member Harvey?
We're going to do roll call.
We can, or we can.
I'm just going to say all in favor, say aye.
Aye.
Any opposed? Okay, that motion passes.
Works for me.
All right. Now it's time opportunity for the public to address the Board of Health, and we've got 5 folks signed up. I'll call you in order. You can indicate if you want to testify. It looks like you all do. You'll have 4 minutes. You've been through the drill. I think you guys were here this afternoon. So I don't have the script, but essentially public comment is opportunity to address this board. We don't allow certain types of comments like inflammatory, discriminatory, hateful. We have the opportunity to restrict your right for a good cause. No comments about commercial things such as promotion of a for-profit business. Electioneering is prohibited, certain guidelines. No outbursts of any kind. Any written materials you submit can be considered a public record pursuant to the Public Records Act. Can't make comments about pending land use permits or anything that could come before Board of County Commissioners on appeal. Doesn't really apply to Board of Health. Please address the board, not audience or staff, and that should do it. So with that, I'm going to go in the numerical order that you guys have put out, which is Megan Costa. And just hand it over to the podium.
Hello, my name is Megan Costa. I'm from Centralia. I work as a nurse at Providence Centralia Hospital, and the statement I'm about to make is my own and in no way represents the viewpoint or opinion of the hospital I work at. In 2020, I graduated into a world of nursing that was in a constant state of change. I work on a medical unit that is meant for patients with a wide range of diagnoses. But during COVID, every bed was filled by a COVID patient requiring oxygen support. Many of our patients could not even turn themselves in bed without their oxygen levels dropping. As we learned more about COVID, our care had to frequently adapt to the most current information. And it was hard, but I was honored to work with nurses who took initiative to research and innovate with our supplies to suit patients' specific needs. These efforts were possible because we were given staffing ratios specifically for COVID patients. In other words, if we had more COVID patients, we were provided more nurses. But now, in the aftermath of COVID, our workloads have increased to a point where nurses are forced to prioritize basic safety in ways that do not promote compassionate care. A patient should come to Providence Centralia and have reasonable expectations met. A reasonable expectation used to mean that they would be healing in a comfortable place with nurses who were able to promote their healing process. But now the safety and care of 7 patients is being assigned to one nurse. This single nurse is responsible for hourly monitoring and trending changes for all 7 patients. A patient can only expect to receive priority treatments now. If they have an infection, they will receive antibiotics, and surgical patients will receive pain control. Respiratory patients will receive oxygen. But there is so much more needed. Additional attention that they are not able to receive from a nurse who is caring for 7 patients. Charting alone for that many interferes with the nurse's time at bedside, let alone the care that requires us to move rapidly from patient to patient just to make sure that their essential treatments are being done. Currently, families call the hospital and no one is available to update them. Surgical patients are being forced to wait to use the bathroom for the first time since their operation. These are vital concerns that, by necessity, receive less priority when a small number of nurses are stretched so far that basic safety and treatment must take precedence over respect and decency. Nurses are people with critical thinking skills trained to make judgment calls in their patients' best interests, not task-oriented shift workers. In one room, we may have a patient at risk for harming themselves and others, and in another room, we may have a grieving family with an actively dying patient. Both those patients deserve more of our presence and more of our attention than what is allotted between them and 5 other patients. We did not come here asking for help 2 years ago when the entire world changed with the pandemic, or last year when the staffing crisis became evident and medical management gave us false promises of help. So please ask yourself how bad it must be now for us to be here asking for help today. Thank you.
Thank you. Next is Miley Alegria.
Hi, my name is Miley. I am a charge nurse on this cardiac step-down unit at Providence Centralia Hospital. The statement I am about to make is my own and in no way represents the viewpoints or opinion of the hospital I work at. Our focus today is crisis and staffing. On the step-down unit, or as in one step down from critical care, we monitor telemetry or cardiac monitoring. A patient might be on this unit if they have experienced chest pain, a heart attack, a stroke, an uncontrolled arrhythmia, heart failure or COPD exacerbation, a diabetic issue, or a severe respiratory illness as COVID or the flu. Our nurse-to-patient ratio is 1:3 on day shift and 1:4 on night shift. We start the shift by getting report on our patients, reading charts, attaining vital signs, and assessing each patient. Medications are due throughout the day, upwards of 10 to 15 at once, including cardiac and diabetic meds that require extra monitoring. During a 12-hour shift, each nurse is responsible for charting an assessment for each patient twice. This is charting on every body system, pain level, mobility, risk for falls, risk of skin breakdown, blood clot preventions, all patient education given during a shift, and an individualized care plan, as well as hourly rounding on each and every patient. If any of these items are missing, the nurse is not meeting minimum charting standards, putting their license in jeopardy. In between all of the charting, the nurse must answer call lights, answer family phone calls, deliver food trays, respond to bed alarms, assist coworkers in cleaning and repositioning their patients, follow physician orders, or fix a telemetry wire when the monitor tech calls. At any time, a patient may go into cardiac or respiratory arrest, fall, throw up, have a seizure, attack a coworker, or any number of events requiring immediate attention. There are continuous cardiac infusions running, which alter heart rate and blood pressure. We give blood thinning and insulin infusions, which require ongoing lab monitoring and titration. It is endless, and makes for a very busy day when caring for 3 or 4 patients. Now double that. Telemetry nurses have been forced to take 6, 7, even 8 patients at a time on both day and night shift. Our unit matrix calls for 10 nurses for 27 patients. We routinely have 5. We recently had only 12 nurses to staff the 5 units in our hospital. That's 97 patients. Our nurses are unable to safely monitor our patients or even perform basic care for them. We are fearful of what could happen to one of the patients in our care. We risk losing our livelihood if an error occurs due to the nurses being stretched so thin due to understaffing. It's not like the shelves won't get stocked or someone has to wait in line longer at the check stand if we don't have staff. People could die. People are dying in emergency rooms across the state. These are members of our community, family, loved ones. A few weeks ago, we had 3 ER nurses for 63 registered ER patients. This is unacceptable and unsustainable. We are not being heard, and more can be done. As a member of this community and a nurse who believes there is good in people, I am asking you to help us as we help you. We are asking you to issue a supporting resolution for all healthcare workers from this body to the public. Additionally, I am asking that the board vocally support the safe staffing legislation in the 2023 legislative session and be a partner in seeking solutions with our statewide representative. Thank you for your time.
Thank you. Next is Kendra Stedman.
Good afternoon. My name is Kendra Stedman. I live in Olympia. I'm a registered nurse. The statement I'm about to make is my own and in no way represents the viewpoint or opinion of the hospital I work at. I've been a nurse for 9 years, 8 of those years at Providence St. Peter Hospital in the IMCU, the Intermediate Care Unit. Over the last 3 years, much has been asked of bedside nurses. During the pandemic, nurses stepped up to care for our community when little was known about the COVID virus and its impacts were high. My unit supplemented our ICUs as they experienced surges of COVID patients concurrent with ICU staffing shortages. For us, the pandemic was characterized by extreme workloads and mental and emotional anguish. At times, we were met with open hostility from an often poorly informed public, resulting in further injury and isolation. Working conditions in the pandemic are a heightened version of what many healthcare workers already endure. We work long shifts, sometimes at odd hours. We deal with violence at the hands of patients. We are constantly exposed to the pain and suffering of others. Many nurses experience moral injuries when we are asked to do things that could cause harm. Although we seem to be past the worst parts of the pandemic, the working conditions of nursing at nurses at St. Peter are rapidly declining. Currently, many units in the hospital are staffed at 50 to 60% of the nurses need to be considered fully staffed. IMCU's staffing plan has a 3-to-1 patient-to-nurse ratio. For months, our nurses may be assigned up to 6 patients, with our charge nurses taking full patient assignments as well. In addition, other vital positions on our unit frequently remain without staff, leaving nurses to fulfill those duties, burdened by an unfeasible number of tasks and responsibilities. The needs of our patients are great. We are forced to care for patients without adequate support. We are unable to respond to needs in a timely fashion. Patients may remain soiled, hungry, in pain, or in fear. When I'm burdened with too many tasks, my patients may experience delays in care that result in notably poorer outcomes. They are susceptible to serious skin injuries if I can't turn them, or even dangerous falls if I'm spread out and running between too many rooms. I worry that I may fail to recognize the subtleties of the patient, and that doing so will result in harm. I'm concerned about the injuries to my own body as I work under high stress and without adequate rest and nutrition during my shift. I cannot fulfill my obligation to patients because I do not have the resources available to support the fundamental duties of my job. When we use numbers to describe patients, let us also be clear. I work with flesh and blood, human beings that are complicated, in bodies that are both resilient and surprisingly fragile. When I say patients, I'm speaking of our community members, your friends and loved ones. I'm speaking of you. My coworkers are remarkable people who happen to be nurses. I've come to work alongside them day after day, and I continue to watch their spirits dim. I shared with a fellow nurse that I've started having nightmares 2 days before I come to work. She told me that she often finds herself crying in her car before her shift. Feels like we are being asked to do an impossible job. These are life and death matters. The fact that we cannot do our job safely is distressing and demoralizing. While nursing shortages are not unique to Providence at this time, Providence administration continues to fall short in creating a more achievable workload. When unit staffing and patient assignments are questioned, the standard reply from administrators is that it's worse somewhere else. While travel nurse and new hire positions remain open and unfilled, our current staff continue to exhaust themselves, leaving more on the verge of quitting. It is far past the time for action. If Providence does not make this crisis a priority, it risks further injuring nurses and our community members. We are asking you to issue a supporting resolution for all healthcare workers from this body to the public. Additionally, I'm asking the board support the safe staffing legislation being introduced next year. Thank you.
Next I have Christy Harridge.
Good afternoon, everyone. I know some of you heard me earlier, but I'm really grateful for the opportunity to speak to those of you who didn't. My name is Christy Harridge. I'm a registered nurse at Providence St. Peter in Olympia. The statement that I'm about to make is my own and in no way represents the viewpoint or opinion of the hospital that I work at. I am here to impress upon all of you the dire healthcare situation that our community currently faces. I have been a nurse for 7 years. All of those years have been at St. Peter. The current situation in St. Peter Hospital is the worst that I have ever seen in my career, including at the height of COVID. Short staffing has progressed from a problem to a full-blown crisis, and it's costing my patients and your fellow community members their health and access to safe inpatient medical care. When my unit is fully staffed, we have 10 nurses and 2 nursing assistants taking care of 30 patients per shift. Right now, we are frequently down to only 5 or 6 nurses and no nursing assistants. Our nurses are attempting to care for twice as many patients as they should be. And I say attempting because that's all we're doing. We try as hard as we can to give our patients the best care possible, but no one nurse can be in 2 places at the same time. And it is resulting in suffering for both the patients and our staff. Our patients are experiencing life-threatening injuries and infections. Our nurses are burning out and they're leaving their jobs, getting injured and suffering work-related trauma and PTSD. A few examples of situations caused by short staffing are that our incontinent patients frequently sit in their own urine and feces for hours because we do not have adequate staff to provide timely hygiene care. This can lead to bed sores and wounds that cause dangerous infections. Many patients are unable to feed themselves, but feeding someone is incredibly time-consuming, particularly if they're confused or if they need extra time and assistance to swallow safely. That means that people either risk choking or they go hungry for hours until someone is available to feed them safely. If I can get 1 full meal into each of my swallow risk patients per 12 hours that I work, that's a good day. Our community comes to us for help in their most vulnerable time. And right now, we are barely able to feed them. While COVID numbers are down, they are not gone. And COVID is not the only infectious disease that requires the use of personal protective equipment. Because of unsafe nurse-to-patient ratios, I am frequently forced to choose between taking the extra time to put on me PPE or getting to my patient in time to help them. If someone can't breathe, or if they are about to fall out of bed and hit their head on the floor, an extra 30 seconds can mean life or death for them. While the alternative is that I risk my own health and that of my coworkers and my family by being exposed to contagions. I am constantly triaging who is at most risk of severe injury or death if I don't get to them immediately. Frequently, there is no right choice, and everyone suffers. There is unnecessary pain and death every single day as a direct result of short staffing. Every nurse that I work with is feeling the same pressure, and as a whole, we are breaking. Nurses are leaving their jobs because the workload and the stress is unbearable. I used to love my job. Now I just survive it, and I hope that my patients do too. I am terrified for the day that there are no more nurses willing to do this work, because our community's healthcare system will collapse, and it will be a direct result of a mishandled and neglected staffing crisis. I am here today to ask for a statement of support from Thurston County in our effort to push Providence to take steps to improve staffing at St. Peter Hospital. Safe staffing saves lives. We are asking you to issue a supporting resolution for all healthcare workers from this body to the public. And additionally, I am asking that the board support the safe staffing legislation that's being introduced next year. Thank you.
Callie Mouse?
Goodness.
No.
Nos. Good afternoon. My name's Callie Noss, and I'm from Lacey. And I just want to say thank you for hearing us speak today about something that impacts every person in our community. Severe short staffing at our hospital. I will say that the following statement does not reflect the opinion of the hospital where I work, and these words are mine. I'm a nurse at Providence St. Peter Hospital. I've been a nurse for 13 years, and 11 of those have been at St. Peter on the acute neurology unit. On my unit alone, in the past 18 months, we've lost countless nurses, nearly all of whom have left due to poor working conditions, unsafe nurse-to-patient ratios, injuries, and severe burnout. The nurses remaining are left with double to triple the workload, like you've heard my peers speak about. This is dangerous for us and our patients. To give you a sense of how short staffing looks on an average day, I'd like to focus on just one type of consequence of short staffing, and that is patient falls. When fragile, sick, or elderly patients fall, they get hurt, and often they don't survive. I would like you to imagine your loved one comes to our hospital after suffering from a stroke, a typical patient on my floor. While in the hospital, he tries to get out of bed on his own. And in normal circumstances, staff would hear his alarm and run to the bedside. We would help avoid the fall and safely assist him. Today, his alarm goes off. There's no one to run to him. The halls are empty because nurses are busy with other sick patients. He's too weak to stand following the stroke and falls face first into the sink. He breaks his nose and has a large abrasion on his forehead that will later require many stitches. Because he takes a blood thinner, he bleeds profusely. The fall itself is awful, but the real problem is that he hit his head so hard, he now has a bleed in his brain. He's rushed to the ICU, where a breathing tube is put in, and a drain is placed to reduce the pressure on his brain. Sadly, your loved one is not able to be weaned off the ventilator. And after a week of desperate prayers and an ICU team working tirelessly to save him, your family makes the impossible decision to remove him from life support. Your loved one didn't survive, not because of the stroke that he came to the hospital for, but because of a preventable fall that almost never would have happened if my hospital was staffed the way it was just a year ago. Our staffing crisis has reached frightening levels that are directly harming our patients. Providence continues to make excuses and is not doing enough to address this problem, so we continue to hemorrhage nurses, just worsening the problem. They could have taken steps to get out ahead of this, yet they chose not to. Please support us in our effort to show Providence that they need to do whatever it takes to attract and retain our nurses. The safe staffing legislation being introduced next year can be pivotal in changing the future of healthcare. So please support the passing of this resolution because safe staffing saves lives. Thank you.
Okay, thank you. I know a few people joined in. Is there anyone else in the boardroom that would like to give testimony? Okay. Do we have anybody? Looks like that's all staff. David Coe? Attorney. Okay, right. Yep. And Scott Neal.
Yes, David Coe's on. Hello, everyone.
Are we just checking if you want to give public testimony, but I don't think so. Because you're
Yeah, I'll abstain from that this time.
okay, Neil Hilton?
No, thank you, Commissioner.
Okay, very good. That concludes public testimony. Thanks to everybody. Commissioner McGinn.
I do have a question in regards to the public comment we received, we also received it at the Board of County Commissioners. You've mentioned that there's a 2023 legislative proposal, and I was wondering who's heading that proposal?
Yeah, so that's gonna be led by a UFCW 3000, SEIU 1199 NW Northwest, and the Washington State Nurses Association. They've come together and formed a coalition. This will be the third or fourth year.
Is there a
that we've
House
introduced
bill?
this legislation, and now it's more vital than ever.
Can you come to the podium, introduce yourself so we
I'm
can capture?
not authorized to give comment. I'm just gonna answer that question for you.
Well,
Could one
we
of
need
you-
to capture that in the public, so
I'll do it.
please do.
Okay, so the legislation is being proposed by UFCW 3000, SEIU 99, and the Washington State Nurses Association.
Is there a proposed House bill or Senate bill that you know of?
I don't believe it's been forth yet.
It hasn't been introduced yet.
Not yet, but there will.
Please, let me give you my card and you can keep me posted on the introduction of the bill.
And then one more question. Everybody mentioned a resolution of support. Is there a proposal, is there a draft that's being proposed by your group or one of these groups, or you're asking us to draft something like that?
Yes, we have a draft that we can.
You need to come to the podium, sir.
We can get all of that information to you. We are putting together, or we have put together a petition that we are presenting to Providence.
Yeah, my email is online. Please feel free to send me.
Okay, yes, I can do that information.
And I'll give you a card.
Can I make a comment? So before I came to this meeting, Commissioner Edwards had asked us to think about like what are priorities that we really care about. And so I asked a bunch of people, like different people, dentists and pharmacists and other doctors, and I will tell you, this was one of the top issues was workforce. And the reason is the few people remaining in all of these positions are dwindling and dwindling and dwindling. And so it is feeling unsafe for a lot of people doing this work. And so I do think it's very important that we think creatively, if we can, about supporting the existing workforce, expanding the workforce, and recruiting people into these positions, because we're all burning out and it's feeling very like moral injury for a lot of people. And so they are not alone. And I will tell you, we're all competing for the same limited number of people still doing this work. And so they're all being recruited away from each other, and then you're constantly rolling, this short staffing. And so it's, I think it's really important. I think this is one of the most important issues that people in healthcare care about right now.
Very good, thank you. Okay, appreciate you guys all being here. There will be further follow-up on this, I'm sure. Let's go to item 3, foundational public health funding. We have Kurt Harden to present, and straight to you, Kurt.
Okay. Thank you, Chair. Kurt Harden, Interim Director of Public Health and Social Services. You should have received this information in the packet that we sent out, that Jamie sent out to all of you. I'm going to go through this, a couple of things. Number one, this is information today, but in January, we're going to ask for the Board of Health to make recommendations to the Board of County Commissioners for the foundational public health funding, that these areas that we're going to talk about here in the next couple of minutes. Also, please keep in mind that as we're going through this, we have been working on, and staff has been working on, on this budget, foundational public health, for the last 5 months. I am going to try to take 5 months worth of budget development and put it into 30 minutes. But at the same time, I'm going to encourage you, if you want to set up a time where we can sit down and talk one-on-one about foundational public health between now and the meeting in January, please reach out to us, because we will sit down, we will get you information, we will try to help you understand, because it is complex. And as staff knows, there's some staff who've been around this for like 2 or 3 years, and they understand that it is complex, and we want to help you understand it as well. So we're going to give you the real high level. Sometimes I like to say, there's a 10,000 foot level, 30,000 foot level. We're probably at the 100,000 foot level right now. But keep in mind as we work through this, reach out to us. Let us know if you want more information. We'll sit down one-on-one. And then the other piece is we start, I know Robin's gonna want to hear this because she's also a budget officer, but we start the biennial 2-year budget process after the first of the year. So I'm hopeful that the Board of Health will appoint a subcommittee to work with public health fiscal staff and programmatic staff as we go through the budget development so that you get a better understanding of the budget, number one. And number two, you're gonna take that budget and make a recommendation to the Board of County Commissioners eventually next fall. But it is almost a year-long process. Is that a good?
Oh, yeah.
Yeah, okay. And so as we guide through this, hopefully there will be a set committee that we can work with as well as we give you the information in the 2-year budget process and go forward. And then, so as we move this forward, just keep that in mind as I go through. Please feel free to ask questions as I go through, but I may ask that we hold something until a more detailed session can be scheduled between now and January. Any questions on that? And I think the first slide up there, I talked a lot, but the first slide, working together to achieve the highest level of health and well-being for everyone, our mission here at Public Health. So moving forward, to the next slide. Ensuring the conditions where children and families can develop as healthy, productive members of the community, thereby reducing future impact on the criminal justice and other systems. So really, the Board of Health mission, the public health mission is very broad, but at the same time, it involves the entire community. We're going to go through the history of foundational public health at a very high level. We're going to talk about 2022 to 2023 statement of work. And then we're also going to talk about some of our related information there. Okay, there's 4 areas of foundational public health. You have them up here, and you can read those yourself, but this is defined by RCW 4370.512. And it really is intertwined here because foundational public health went through a process where the state in the legislature defined the core areas, and we have 11 tasks that we'll get to here eventually, but the core areas of public health. And those areas are places where no one else does this except public health departments. In other words, foundational public health is predicated on, and I've used, you probably heard me use this, vaccination in the, before. Vaccine or vaccination is done by multiple healthcare providers. However, education and helping the community understand the importance and answering questions about vaccination typically is only done by public health. And so that's kind of the nuance when we talk about foundational public health versus all the other areas. So for our next slide, here's the task and the core areas for foundational public health. And I will tell you that the core public health services, communicable disease control, chronic disease injury prevention, maternal child family health, access to clinical care, environmental public health, and vital records, all that. We'll talk a little bit more as we go through that, but you have the long-winded, I shouldn't say long-winded, the explanations to the left, but it's simply what does public health provide that no one else does provide. Next slide. So talk a little bit about this, and part of the problem is that there's been an inadequate funding and resources for public health, for public health services. And this is not just over the last several years, it's been a number of years. And those who've been in the healthcare sector know that this has been that way. It's inequitable funding also across the state. So with the inconsistent funding structure for government public health, they saw a need to modernize how governmental public health does its work. And this is the solution that we're talking about. They've defined it, and you'll see that, defining governmental public health system. And then the limited statewide set of core public health services we just talked about previously. And then what's happening is the state has started putting sustainable funding towards public health, foundational public health. So what I'm going to talk about is sustainable funding, and then also there's going to be new funding anticipated every July 1st for the next several biennium with the state. And we also go off of state fiscal year. So the state fiscal year is July 1st to June 30th. And that's how the state set up on the fiscal year. That's how they appropriate funding, and that's how they give us the funding. Our fiscal year is set up January 1st to December 31st. So you can see there's a little bit of, I don't want to say conflict, but a little bit of juggling that we have to do and decomposition to make all that work. And then you can see down here that defining the roles for state and local government. So next slide is main points. So state fiscal year 2023, which started July 1st, 2022, we're receiving $2.6 million in foundational public health. That's Thurston County's allotment. Of that amount, $526,468 is unobligated. In other words, we're coming to Board of Health for recommendations to the Board of County Commissioners because, again, the Board of Health makes recommendations for funding, but the Board of County Commissioners is the body that obligates the funds. And so we'll go through what the staff recommendations are for the Board of Health for this funding. So here's the request the staff has put together. First of all, task one, and we're going to go through the tasks as well for foundational public health, the 11 tasks. There is $1,320,000 in task one. That's already fully obligated. And keep in mind, this funding started in 2021, correct, or earlier?
Actually, it started a little earlier, but the big infusion came in 21.
Okay, but anyway, so the $1,320,000 is already obligated. That was in previous budgets. And so what happens when it gets obligated, it becomes maintenance level for the next budget year. So as you walk through and I see that this is already fully obligated, it's already been obligated previously by the Board of County Commissioners. And so it's part of the maintenance level as it moves forward from budget year to budget year. Task two, and then we go back to task one. Task one is funds that may be used to provide any of the activities described in the most current version of Foundation Public Health definitions. It's got the greatest flexibility for funding, but it's already obligated because it was obligated in previous years. Task two, funds are obligated to support local health jurisdictions' assessment capacity to meet locally identified needs. This $60,000 is already fully obligated as well, so no decision is needed. Task three is assessment funds to each local health jurisdiction for community health assessment. And so these funds support any community health assessment and community health improvement plans, should be plan, not plan, activity or service, focus groups, report writing, processes, facilitation that may be used to contract with other agencies. In other words, community health assessment, community improvement plans, this is task three. That's already fully obligated, and the $30,000 there, no decision is or recommendations needed. But I'm taking you through this to show you all the different 11 tasks. Task four, communicable disease, hepatitis C. The funds are to address hepatitis C cases per guidance developed by the statewide Foundation of Public Health Services Communicable Disease Work Group. It's including but not limited to the shared priorities, standardized surveillance, minimum standards of practice, common metrics, and staffing models. Again, $55,000 for here, fully obligated, no decision necessary. And then for task five, communicable disease case investigation capacity. These funds are available to support local health jurisdiction communicable disease capacity to conduct case investigation and follow up to reduce gaps and meet locally identified needs and address notifiable conditions. We have a list of notifiable conditions in public health that are required to be notified to the state. And we also, under those, have their various responsibilities, but many of them require case investigation capacity. This $378,000 is already obligated, but it does tell you that we do case investigation process for communicable disease in a number of areas. Task six is where we're going to get to some recommendations. This funding is allocated to expand capacity to conduct timely investigation for all infectious TB cases, conduct outreach and evaluation to Class B arrivals and infected contacts, provide education and resources to promote engagement with community providers and coordinate case management for patients with LTBI. This $20,000 is there. I'm going to come to where we start with our first staff recommendations in this area. The first one is Survey SMILE and the implementation of the SMILE survey. And that's going to be a county level survey for rural and urban schools that will be comparable to state and provide a local profile of dental decay in elementary age youth. The data collection will guide oral health program as a program indicator. The recommendation is to take $6,260 for a one-time purchase cost and then also utilize current staff for that one time to implement Smile Survey purchase costs there. And then the second recommendation is to purchase the Atlas TI qualitative analysis software to aid in the data analysis of community health assessment interviews and focus groups. The ongoing subscriptions allow staff to use the software concurrently, and the required community health assessment is due in 2023 and requires qualitative and quantitative data collection. $1,199 initial software purchase and license and $400 recurring annual license. This allows staff to use the software for the data analysis for the community health assessments. And then the third recommendation is expand capacity to conduct timely investigations for all infectious TB cases, conduct outreach and evaluation to Class B arrivers and infected contacts, provide education and resources to promote engagement with community providers and coordinate case management for patients with LTBI.
Can I ask a question?
Yep.
I have a question in regards to the task 6. And I might be completely wrong and I might be reading it wrong. I thought task 6 was for TB, but we're doing a Smile survey and then the software to kind of aid in that. So I'm wondering how it connects to TB and task 6.
So, from my understanding, and I'm not the expert here, and I know if Steph want to jump in, feel free, but or Dr. A. But my understanding is this is a element under that's eligible. Now, and task 6 gives overall broad guidance, but we've checked on back to DOH to the subject matter experts there, and they said that's an eligible purchase under task 6.
So it gives a broader allowance than just TB then?
Mm-hmm. That's my understanding. Is that, anybody have additional information? I see heads nodding in the audience. People's far smarter than I.
LTBI for the
Latent tuberculosis infection.
Thank you. I know what it is, but I don't know what the acronym is.
okay.
But they're working to get me up to speed by January.
Thank you.
Other questions on task 6?
So just to be clear, there's $20,000 allocated to task 6, and then the recommendations are additional funds? Or are we talking about how to split the 20,000?
No, the 20,000, we're talking about the $16,760 that are available, that are left over from task 6 that haven't been obligated yet, and that's available for decisions, and that's what we're talking about right here.
Okay, so there's $36,000, 20,000 of which has been obligated already.
I believe so.
Okay.
Going on task 7. But yes, sir.
What kind of
Related to the IT software purchase recommendation, we have an internal process in the county that we need to go through the ITC, the Information Technology Committee.
Mm-hmm.
So I just want to bring some perspective to the board members. There's another process that we vetted through the process where an IT purchase really brings value to the overall system in the county.
I would, if I may, add to that though, that this dollar amount, $1,200.
We just approved a $5.8 million
below
software
the
purchase.
amount that goes to the ITC. The department has authority to just do this. They don't need approval of any board, with all due respect, to go forward with this purchase.
Right.
The amount is negligible.
Okay, and so since this is the first task that has, recommendations attached, can you walk the board through what, just focusing on this as an example, what is it that you want us to do? You want us to consider, at January, we're gonna discuss whether we want to approve these recommendations or what?
Or other recommendations, and thank you for the question. either recommend approval of these recommendations and they go to the Board of County Commissioners, or bring forward other recommendation, or recommend that we give the money back because we have until June 30th to expend these funds. If the funds aren't expended by June 30th, then they go back to the the Department of Health.
Since we're just opening it up. Can the Atlas TI software program help with things like the dental survey, the smile survey? Like, would you use that for many different kinds of analysis of data that's collected by the county?
And I think this is, did somebody else want to talk now? Because I think Mariana O'Gara was on the call, and she was going to talk to a different part of the agenda, but this is also, I believe, this might be in her area. And I was going to ask Mariana if she wanted to comment.
Sure, if that's okay. I'm Marianne O'Gara, and I'm a senior epidemiologist here at Public Health and Social Services. And it's great to see you discussing this together. Thank you so much for considering it. With regard to the Atlas TI qualitative analysis software, we did a big extensive review of options that would fit local public health departments and qualitative options, and you are absolutely right. It is a multi-purpose use in terms of once purchased, it allows us to examine transcripts, interviews, notes from a range of different processes that we use, which we do also for things that we collect as a department, and sometimes we do in partnership with others. So there's community partnership potential. One example is we're working with a local hospital who did a lot of stakeholder interviews, and that could support, if it was available to us, a look into some things that are unique to some of our stakeholders' interest in what that data shows us versus what a hospital might be interested in. It could be used by environmental health doing stakeholder focus groups. So you're absolutely right, multi-purpose.
That's great.
Okay.
Thank you.
All right, go ahead, Kurt.
Okay. Other questions on task 6? Okay. Going to task 7, climate change response, environmental public health, climate change response. Funds are available to respond to education, communications, and response needs for wildfire smoke and harmful algae blooms. Establish capacity to contribute to the public health education, communication, and response efforts necessary to reduce the public health impacts of wildfire smoke exposure. Help communities prepare for wildfire smoke events through education, community engagement, guidance development, and emergency response. Reduce reliance on the Department of Health toxicology capacity regarding HABs, assessment, messaging, and next steps. And then provide adequate funding to collect necessary samples or pay for laboratory costs. So under the recommendations here, a harmful algae bloom and air quality, fire-related update response strategy, and complete harmful algae bloom assessment of Summit Lake. That is, looking at that, is $50,000 one-time cost, and there would be a contractor and contract lab support. By the way, the total amount for this task that to be obligated is $80,000. And then smoke response plan, health impacts, $30,000. That's the recommendation.
Can I ask why algae blooms and fire response are bucketed together?
So I'm Art Stark. Do I need to speak here or go here? So I won't say involved with, but watching this. And the attempt with, when this was set aside, I believe, was to recognize that climate change response for environmental health activities, a lot of it there's a kind of limited things that we typically get involved with. And one of the things that warm weather and weird climate conditions do is contribute to increased harmful algae blooms. And when those occur, then we have a response. And the reason we're proposing Summit Lake is because it's a drinking water lake, and if it's the most sensitive area in our county when we do have a harmful algae bloom, and we had one a few years ago, which basically shut down the lake for months. And so that's why we're proposing that. And the same thing with climate climate change, one of the things that's associated with that is increased wildfires. And as we know in Western Washington, we're being impacted by that more and more, both in terms of, well, you were at the meeting last night, wildfires in Western Washington, as well as the smoke impacts from wildfires either in Western Washington or Canada or Oregon or California, wherever. And so we need to have a better response strategy for that. There's a lot of tools available for that, but we haven't implemented them. Last year we were scrambling a little bit, and we want to have a better plan for coming forward because we're probably going to get to use it.
And for the board members who may not know that Art is our division director for environmental public health within the public health department.
I should have said that, sorry. Thank you, Kurt.
And he sits on the statewide subject matter expert work group for this area.
Well, I monitor it. I've been involved with a lot of stuff. Yeah, thank you. Don't just say here.
Stay there, Art.
Oh, no. I'm on the hot seat.
Stick around.
My question in the smoke response plan and health impacts, I'm wondering, is there going to be coordination with an outside agency like Ortho, for example?
And that would be part of it. There's a lot of people who are involved with that. So there's different agencies who issue warnings and provide information. So trying to coordinate with them is going to be really important. Our different partners who are involved, or schools, different employers and things, how to review the information, what's going to be the trigger for decisions by Dr. Abdul-Malik on advisories and things. There's lots of good information there, but we haven't had a chance to work on it as well as we'd like. So the short answer is yes. We need to work with those folks, and that would be part of the plan. As well as also with our emergency management folks. That's a key group that we need to work with.
Thank you.
Okay.
Good. Thank you, Art. Okay, moving on to task 8.
That's mine too.
Yep.
I'll stay here.
Get some coffee. Anyway, toxicology, environmental epidemiology, conduct investigations, research, communications, and data analysis related to toxic exposures. Local health jurisdictions will work with the Department of Health and Tribes to identify environmental epidemiology, toxicology, and community engagement needs and conduct needs assessments on needs for a model program to place capacity closer to the communities potentially affected. Staff recommendations, and I'm going to go out here and say the total for this task is $35,000 available for funds for decision. Where the subtotal, I should say, for the task, adding that up, is $35,000. The available amount is $51,793. That's a change. It's not $25,000. It's $51,793. And then the on recommendation number 1, outreach, monitoring, communication in Smith Prairie regarding nitrates. That's not $40,000. That's a correction to $30,000 one-time cost. And then the recommendation number 2, nitrate sampling outreach in Smith Prairie area. That's not $10,000. My apologies. That's a $5,000 one-time cost. So those are the 2 changes there.
Remind us where Smith Prairie is and why that's a
that's actually out by Lawrence Lake, Bald Hills area. So Commissioner Edwards knows that area well. And what's happened was this summer, as part of a certificate of water availability process, and that's something where people have to go and get testing done when they drill a new well, propose for a new single-family home. A well sample showed very high nitrogen levels, and nitrogen's a primary contaminant of concern in drinking water. And when we did some follow-up work on that, even though the area is mapped as having, through our geodata process, is showing an area with elevated nitrogen concerns, we found that the area seems to maybe have shifted. And so what we're proposing to do is work with the community to let them know about this information that we found, to do additional work with the county hydrogeologist to design a sampling program and to conduct testing in the area to better characterize that area, because we want to make sure that we've got the current limits of the area with elevated nitrogen, if it still exists, or how big it is, because it is a public health concern. We want to make sure that people who are in the community are aware of that and are made aware of steps that they can take to protect their health if their well is producing water with high concentrations of nitrogen.
I have a question. When you say high concentrations, at what level are we talking?
So the federal and state standard is 10 milligrams per liter, and that high nitrogen is particularly a concern for infants and some folks that causes something called methylhemoglobinemia or blue baby syndrome. The concentrations in the well that were sampled we're at 38 and 41 milligrams per liter, so 3 to 4, well, actually 4 times the standard. So that's quite a bit higher than we would expect to see in the area, which is why we're concerned.
Now, there was a big chicken farm out there at one time. I don't know if it's still going.
Yeah, there's different agricultural activities out there, and that's one of the things we want to do is see if we can if we find that there are elevated areas and see if there's land use activities associated with that, so we can work with those people to,
I might add, it's quite a forestry area, and nitrogen is applied to the forest to make the trees grow so they can cut them faster and make more money.
Right, and that's gonna be part of the, again, not trying to get into study design, because we haven't really designed it yet, but that would be the sort of thing to do, is to look at land use activities, to see if there's a relationship between the monitoring results and the land use activities, to then work with, property owners and partners to see if we can reduce pollution, if that's what we're seeing.
Thank you.
I have a question on the map. I'm trying to figure out, so there's 75,000 total allowed in this bucket, or there's only 35,000?
No, it's, subtotal for this task is 35,000. The numbers are actually 30,000 for task 1 and 5,000 for task 2. Those were adjusted. My apologies for the incorrect numbers. And then the amount remaining is 51,793. That's amounts available for decision. It's not 25,000. It's 51,793 is the amount remaining. We'll get the updated slides out to you.
51,000?
51,793.
So that's beyond the tasks that you're recommending?
What's that? No, the amount, yeah, there's additional funding left over. We'll get to that at the end about some one-time eligible recommendations. Okay. And then the 75,000 is what's already been obligated, is my understanding. Is that correct, Art?
I thought there was 75,000 total, and then we were proposing this project to use part of that, and would remain, looks like the numbers have changed a little bit, but a large chunk of it would be going for water quality sampling. The other piece to this would be to offer free water quality tests for the community using for nitrogen, so they could see what the levels in their well were, since we'd be telling them about that. So that's the second part of that budget.
I'm confused, yeah.
Clear as mud.
Yeah.
So there's,
Maria, but I don't know.
Oh, well, I mean, are you saying then that 75 is the total and 35 of that is what is being recommended?
No, the available funds that need to be obligated that we're making recommendations.
So the only thing available is 51,793.
Correct.
And you're asking for 35 and the 75 has already been obligated.
That's my understanding. Is that?
I don't think I got
Because
that.
I thought there's, and I may step into the muddy water here. There's $75,000 being offered for this particular kind of category of things as part of the consolidated contract this year. So we were proposing to use $40,000 roughly for this project out of that
Correct.
Category.
Well, 35,000, correct, but also at the same time, what's that?
Or
You just said
40, I
40.
mean, there's all kinds of numbers on these.
No.
40 minus 75 leaves 35, and you keep saying 51,000.
793.
My recommendation
There's no way that.
I'm gonna wait for the updated
is
slide.
that we don't pay close attention to the dollars, and we
We will-
will
we
work
will-
together to get you a table of the correct numbers. So I think that the numbers on these pages are confusing. Just
But-
ignore them for now.
But
They're
the
green,
projects
they're hard to
themselves,
see, so.
yeah, and the projects themselves are what we're recommending for the Board of Health and Insurance.
Bottom line is, there's 2 projects, and then there's some extra money.
There's some money, but you
That
have
we're gonna
that.
talk about later.
So I think you've got it.
There you go.
So let's move on then to task 9. And that task 9 is fully obligated, no recommendation requested from the Board of Health. And same with task 10, maternal child health review. But I want to go back, system-wide data management improvement for environmental public health. Task 9, that goal, the long-term goal of this investment is to increase data management teams at the local level, ensure there is a core team at the Department of Health to support and help establish local health jurisdictions. And they will work closely with the Department of Health, Environmental Health, data management teams to identify a strategy for data sharing. And then task 10, child death review. This investment assures local health jurisdictions and Department of Health have adequate staffing to conduct regular child death reviews and use their findings to track fatality data and inform policy recommendations to reduce and eliminate preventable child deaths. Allocations are for staff and operating costs for 9 local health jurisdictions. That's fully obligated, no recommendation needed. Then we're getting to task 11. This is a large chunk of the funding for foundational public health, life force, for infrastructure and workforce capacity. So these funds are for these 3 areas: maternal, child, family health, and then access linkage with medical, oral, and behavioral health services. And then the third one is chronic disease, injury, and violence prevention. And then the areas of recommendation here are, number 1, meet our department's short and long-term strategic goals of improving the breastfeeding rates in Thurston County, and using the maternal child health staff to do that. The second recommendation is a half of an FTE to provide staff supervision for foundational public health positions. And then the third one is conduct an annual program of health promotion, communications, and presentations, which that $48,615 is the cost that for the half of an FTE for an education outreach 1 person. And that's in white, but it should be in green to show the recommendation. So those are the 3 areas we're recommending for that have available funding for task 11. I think you want me to call them folks, Chair, or you want to call them the people raising their hands?
So number 1, you already have a 0.75 FTE, and you're recommending an additional 20% FTE to bring that up to 95% FTE? Why didn't you just go for the full FTE?
Thank you, Rich.
Hi, I'm Gretchen Toller. I'm Division Director for Maternal Child Health Nurse-Line Partnership. And we originally I had 0.25 down, but we were trying to fit within that $130,000, trying to stay in budget, so I had to drop it down to 0.2. But yes, 0.25 would be ideal, but.
And so let me tell you something else that we think that might, we think that there's going to be unspent funds that are eligible for something that may bring that back up to that 0.25, what we're talking about. An example of that would be is there's always a delay in trying to fill positions. So if a new position is authorized to start January
Salary.
1st, yep, you have salary savings, exactly. So we have some one-time and some other recommendations after this, that if funding becomes available, we're going to ask the Board of Health to recommend that these areas be funded as well. That'll come here shortly.
My question is, so this one has the access linkage with medical, oral, and behavioral health. So I'm wondering why, the other one got chosen for the SMILE survey and implementation, rather than this bucket.
But this bucket is, I'm trying to show you, we're recommending both, I think.
Yeah, but you're recommending the SMILE to go under, the
Right.
SMILE survey to go under task 6. So I'm wondering, could it not go under task 11 as well?
Yes, except we're running out of funding under task 11, so we
So
went
that's
back to see if we could fit under task, was it 2 or, no, task 6.
Okay.
And to see, and they said yes, and so that, we had to move money around, because we're limited by the buckets, by how much money is in each bucket.
Okay, thank you.
But you have extra in task 11.
What's that?
But you have extra in task 11.
No, our requests are 134, actually, that's a change, we'll get you the updated numbers. The actual number is 134,615, so don't look at the numbers. Don't look at the person behind the curtain, just.
I think we had around 130
Yeah,
remaining, but the needs are great, and we have a total positions to ask, but we had to move some out. We're like
Correct.
240,000. So
So the answer is that we are still short on funding in task 11 based on that. So that's why we put the SMILE recommendation into task 6.
Okay.
I have a question that, with the health promotion communication presentations, is it already set what those are gonna be, or is it gonna be responding to the needs of, like, that we're seeing in the community?
So this position, it's in education and prevention, and it is working on a couple different things, nutrition, physical activity, and staff time to participate in Thurston Thrive. So it basically would replace some general fund that we've had for a position for staff that participates in the Thurston Thrives meetings, and does some work around the nutrition and physical activity.
And one of the criteria for foundational public health is this funding, if it takes the place of other funding, use that other funding in areas in public health that are not eligible for foundational public health. So to expand the public health services in all areas. So when Gretchen mentioned taking some of the general fund and freeing that up, that we would look to take that and make a recommendation for the Board of County Commissioners to put that somewhere else in public health to increase services in another area.
I just want to say to our new Board of Health members, the Board of County Commissioners this is one of the most complex areas that we've grappled with to ourselves, and we've been working on this for months, almost a couple of years, so don't be daunted if this seems really confusing. It's still confusing to me, and we've been working on it in work sessions for months and months and months, so apologize for that, but it's just quite confusing how this funding is divvied up into 11 tasks, and we got one level, and then we got extra level, we'd already obligated some, so now we have this extra, some of which goes into the same programs, and then other ones we're trying to make available for discussion here, so it's kind of a complex scheme we're stepping into.
And I would say kudos to staff because I've been trying to get my arms around it since January. And I may get a rudimentary understanding by next month when I then turn over to David.
Question. Are there any current recommendations for medical or behavioral health services? Because it looks like to me that the recommendations for this task are for maternal, child, and family health, but no medical or behavioral health. Is that correct?
So there's, under life course, there's maternal child health, chronic disease, access and linkage, and
These three
Right, I see these three.
Yes.
But then when it comes to the recommendations, it doesn't seem like it falls under these three. It looks like it falls under number 1.
Which one is it?
Maternal, child, and family health. I mean, I could be wrong if I don't.
I think what you're looking at is this is the unobligated funding, but it's not where there's already a large amount of funding has been obligated by the Board of County Commissioners from the previous year and then already through this year, so.
That might go to those other areas.
Yes, exactly, so what we'll do is we'll try to pull together where the other funding areas are and where the other areas are resourced by obligated funding and give you that may answer your question.
It's hard to know where gaps are, I don't know where. So maybe like a heading for each task and just a few bullets of where we've already, when it's already obligated, a summary, so that we can see where the money that's quote unquote obligated is going, and how the new recommendations fit.
Would probably also be useful for this committee to see the entire funding for public health. This is only a small piece of it.
Right.
So there's a significant amount of money in public health that goes to, for example, mental health and behavioral health services. So, yeah.
But I did not want to go into the entire public health budget because.
It's hard to make choices about the minor things when you don't know the big picture.
But I realize you're drinking from a fire hose already, and I don't want to turn up the volume, so to speak.
If I could just add though, we do recognize the need for work around mental health, and so that is one of the proposals that we did have But unfortunately, just due to that limitation of the 130,000, we moved that over to, you'll see it on the last couple pages for, in the list of recommendations for if there's additional funds.
And keep in mind, so far, the Foundation of Public Health is a sustainable fund source from the state, and they're going to the legislature, and the legislature is supposed to look at and find additional resources starting next July 1st of 2023. So in addition to what's already here, additional funding is going to be looked at by the legislature. But great questions. And if you go to next, and then next, and then one more next. So here's a list of recommendations if funding is available. And again, I started off by saying, earlier I said that we believe there'll be some underspending in certain areas just because of, as an example, hiring staff and the time delay for hiring staff, or some staff, some positions are difficult to fill. We've had epidemiologists. We've had a challenge filling an epidemiologist position is one example. So as we walk through these, and I won't read them off all to you, but these are areas where we're going to recommend also funding, if possible, if there's additional funding left over. And one of the things we're going to look at is as of March 31st, where we're underspending, we're going to come back to the Board of Health and Board of County Commissioners and say we're underspending in these areas. We recommend shifting the resources over so that we can fully implement the programs and don't leave any money on the table.
So the board should look at this list of 9 things and kind of maybe prioritize in their own head for discussion next month. If there's where we have extra money.
And the prioritization is important because if we have extra money, say we have an extra $50,000 and there's 100,000 worth of priorities here, we'll do them 1 through whatever until we expend them 50,000. If there's funding available. And believe it or not, some jurisdictions, well, all jurisdictions turn back money, and so we may get like a call from the State Department of Health to say, hey, we've got extra funding available, do you want it? And if we have prioritization projects like this, then we can work quickly to work with the Board of County Commissioners to accept that funding.
Okay, is that where we need to get to, Kurt?
That's where we need to get to. Next slide is, it actually should, it doesn't have my name, but you should feel free to send it to me. Questions, comments, we'll work with you or send them to Jamie and she'll forward them to me. And if you want some more one-on-one, we're happy to do that as well.
Okay, any final questions on this topic? I know it's
I will hold my questions
a lot.
for now.
This might be a place to plug in and take Kurt up on his offer, if you guys have time. Because this is one of the most confusing things you'll have to do. Okay, very good. Well, looking at time, let's move on. We have a couple other pretty major items to cover. Next is the Nisqually Reach Septic System Monitoring Program Review and Reenactment. Every time I say reenactment, I think I'm going to dress up.
I know, we should do a play.
And do
Get the
something.
skin and it's like spread your legs. I'm good with that.
The 1990s.
Okay.
Go ahead, Jean, introduce yourself.
Oh, yeah. My name is Jane Mountry-Venning, and I'm a senior environmental health specialist in the health department. And the reason we're talking to you today about the Nisqually Septic Operation and Maintenance Program is because when it was enacted, it came with a sunset, so it sunsets the end of next year. And so at some point next year, you'll need to make both the Board of Health and the Board of Commissioners would need to make a decision about whether to continue it, to change it, or to let it sunset. So I want to give you a little bit of background about that. Can you guys hear me okay?
Yeah.
So I don't usually read slides, but I am going to read this one because it gives you some background as to why we have this thing in the first place. Because it's been long enough, we kind of lose track. And it comes from state legislatures from the state, who says that the legislature finds that shellfish harvesting is important to our economy and way of life. Washington State is an international leader in the cultivation and production of shellfish. However, large portions of the state's productive recreational and commercial shellfish beds are closed to harvesting, and more are threatened because of water pollution. The legislature finds that the problem of shellfish bed closures demands a public policy solution that the state, local governments, and individuals which each take strong and swift action or this precious resource will be lost. So they found that in 1992. They also found that the failing on-site sewage systems or septic systems were a significant cause of shellfish bed closures, and local health departments should be utilized for remedial action. Next slide. And so there are, commercial shellfish areas throughout this, well, not throughout the whole state, but throughout this side of the state where there's saltwater. And next slide. When there is a downgrade in what's allowed for shellfish harvesting, then that means that the county must take actions to fix that. And that's what happened. In 2000, the State Department of Health downgraded 74 acres of shellfish growing areas in the Squally Reach because of fecal vulva. So we needed to form a shellfish protection district, and it needed to include aspects of septic monitoring and operations and maintenance. So that's what we've got. So you go to the next slide. And the shellfish district was kind of authorized, or was formed in 2001. It took a few years to get going because there's implementation. We'll talk about that. We had a committee. Similarly, in the Henderson Inlet had a shellfish protection district that got started a little bit earlier. So they went first. They got underway in 2007. So next slide. We learned some lessons from Henderson as we started to roll out and implement the program. So again, we're looking at all the sewage that's being treated in people's front and backyards in parts of the county that drain to the shellfish beds. And we need all those individuals to properly take care of it. And many of us, didn't necessarily come up knowing how to do that. And what we find is that people need to be reminded to take care of it. It's certainly an out of sight, out of mind kind of situation. And I know that, particularly as we get older, those years go by much more quickly. So any number of people, when you sort of get in touch with them and let them know, oh, it's been a while since you've received a report, you need to get one turned in. And they'll say, oh, I just did that, and then you look at the record, well, really, that was 5.5 years ago. They're like, oh, I thought it was just last year. So those reminders are very helpful. What we've also found is that not just we think the old systems are probably getting creaky and they're more likely to fail. And that's not incorrect, but new systems can also fail. Particularly, say there's a leaking faucet that nobody knows about, or leaking toilet that's running. And that can drown your drain field. You might have something that's gone on the ground and didn't get sealed correctly. So there's any number of things that can happen, even to new systems, they're not operating correctly and are causing a water pollution problem. And then the other thing we found from the Henderson program is that there are many minor repairs. And some of the most common ones were, which is what this is a picture of, is that the outlet baffle needed to be repaired. There's gases produced in the septic tank that are very corrosive, and it eats away at the cement. And then that can cause leaks that let, again, the sewage to go out where it's not supposed to go and cause some problems. And that's a relatively minor repair, pretty easy to fix. But, who notices this thing, right? You don't pay that close attention. So paying attention, finding these kinds of things. And there might be holes, cracks in the septic system, in the tank, and then again, that corrosion, maybe the pipe that's going out to get the effluent out to the drain field has come loose and it's all pouring right there underneath the tank and not getting treated properly. So things like that we find pretty commonly. Next slide. So as I mentioned, the program sort of was authorized, and then it took, in 2009, it took a few years to get up and running. So we had a lot of just program development that was going on. So things like establishing what exactly is the boundary. So we only wanted systems that were located where they were gonna flow into Nisqually Reach. Establish the risk level. Are they high risk or are they low risk? What are their operational certificate guidelines per system? Die tests, getting an electronic reporting system, figure out what the fee should be to cover the costs, all that kind of program development. So that happened, and we got ourselves a program. Oh, sorry, next slide. So the boundaries, and this is kind of a little bit of the business side, but the yellow side is Nisqually Reach, and where the hash marks are, so the northern part of that, is the part that's included in the septic operations and maintenance program. And in both Henderson and Nisqually, there's more in a shellfish protection district, but some flow studies and further work determined that if a septic system was leaking, say at Lake St. Clair, by the time any of that bacteria got out to the shellfish beds in Nisqually Reach, the bacteria wouldn't be viable, so it wouldn't cause us a problem. It might be a problem in the lake, but not so much for the shellfish. So they weren't included in the boundary for the septic operation maintenance program. All right, excellent. Yeah.
Where can I see a more, a high resolution map of this to see what the boundaries are?
I know it's on our internal geodata. I don't know if it's on the
It's on
external.
geodata. I can send links to it though. It's just for slides we had.
Yeah.
Limited choices.
The PDFs don't go onto the slides very well. So program cost, currently, program, what it includes. So if you are covered by the Nisqually Septic Operation Maintenance Program, you need to have your system inspected either every 1 or every 3 years, depending on your type of system. Most people it's 3 years, but the really fancy systems or high complex ones need every year. If it needs to be pumped, then it needs to get pumped. If there's, again, minor repairs that are needed to make sure it's operating correctly, those need to be done. Or more major repairs that require a permit, those would need to be done. The system cannot be failing, and if you are a high risk, which means you're close to the water and you're sitting on poor soils for septic systems, then you need to have a dye test it's just been expanded from 6 to 9 years when we renewed Henderson. So if all those things are fine, then your operational certificate, which is also called OPC, is renewed and it's issued and you're good to go for another 3 years. 1 year, depending. Next. So to cover that, our costs currently are $71 if you're a low risk system, which means again further away from the water or on better soils. $168 if you're a high risk system. Community systems have more than 2 households or units on one system, or schools or food establishments have a different fee structure. And then, I love this term, $10 for every additional unit or unit volume of sewage. So if you're something, I don't know what, but you're say a kettle or something and you're producing sewage, there's calculations that we use to figure out how much sewage equals the equivalent of 1 household. Don't you wish you had that done? Unit volume of sewage. So anyway, we also realizing when we developed the program that this could be a hardship for some. So some of the things we do to help mitigate that is we do offer a free class to become certified to inspect your own septic system, and those continue to this day. We've certified over 1,000 people just in the Nisqually Reach watershed. We also offer small grants of up to $500 for people who are low income, and we have criteria around that, to be able to do regular inspections or maintenance or pumping or minor repairs. If it turns out that you have a much bigger repair that's needed, there is a program through Craft 3 Clean Water Loans that's kind of co-funded through the state process that makes low interest loans available. And then if you're on the senior disabled assessors list, then you don't pay the rates and charges. You get our program for free. Question?
Well, I'm just wondering when I can ask without disrupting things. I'm trying to, I just know I'll lead the page, I guess. Jane, the $10 for each additional residential unit or unit volume of sewage discharge on property. When we went through this with the other group, which group, Art?
That was Henderson.
With Henderson?
Okay, with Henderson, we changed that because there were a lot of properties out there that say had a trailer park on them. And each one had their own septic tank. And where a owner of a property that had 2 houses on a property was paying a substantial amount. But the owner of the property where there were 40 was almost getting a free ride. Because maybe 1 or 2 were paying the regular rate, and then, the rest of them were getting off with $10, which to me was criminal, that it was even enacted that way. But we changed it.
Yeah, so
Has this been changed yet?
So this is what we changed Henderson to, because after we started Henderson, we found we didn't think there were so many properties that had multiple multiple connections to a system. And then we realized, after doing that work, there were several of them. So we fixed it by using this language that's in Nisqually. And when you reenacted Henderson, we put this language back in, or we asked you to put this language back in. So we fixed it, and this is the correct way to deal with it based on your concerns.
But the $10 is still, I'm trying to figure out the $10.
So what you're doing is you pay the $1 amount, then for each additional unit volume of sewage, there's $10. So if you had 10 unit volumes of sewage plus something, you'd have to pay 71 plus $100. So that's the rate we came up with. So it gets closer to it, but that's what we agreed to after when we renewed Henderson, and it was based on that.
I thought we got it up to a more fair price.
In Henderson originally, we didn't have the plus 10.
We didn't have the plus 10,
We
we just
just
had the
had,
flat fee.
we assumed that every property had one septic system.
is that
And it
what-
turned out that
Yeah,
that wasn't
so-
true.
Jane explained it better than I did.
But is that even fair? I mean, I'm trying to think of the whole process.
Well,
and
that's something that
benefiting,
we'll work on in this coming years to look at that, because there's different approaches to it if you choose to reenact the program. So we can provide some options for you to look at if you'd like.
I don't know, I just think that's one of the bigger issues that we have to deal with.
Jane, we've got,
Okay.
we need to probably
Okay.
accelerate the phase.
Yeah, let's move on. So what do the program fees buy is a good question, and it pays for the staff to do the work, to keep the property rolls, on the tax rolls, to manage the septic system records, to when the reports come in, to review those and decide, yep, this looks good to go, or this looks iffy, or we better go visit this one because something doesn't seem right. So we do, again, follow up on the inspection reports, quality control, inspections. The high-risk properties, again, the waterfront or the ones with poor soils, we do the dye test every 6 to 9 years. Provide assistance to homeowners, technical assistance, do the classes to certify folks, all of that. So that's what the money pays for, again, for the purpose of keeping those shellfish beds open. And just a note, not everybody loves shellfish, right? But shellfish it's mandated by the state, but it's also, they act a little bit like the canary in the coal mine. that if the water's not clean enough to grow healthy shellfish for us to eat, the water's not really clean. So that's a concern for everyone. Next slide. It's working. And our goals were to maintain water quality in the areas that were already approved, and we have had no downgrades in 10 years.
Click the next slide.
No, right there. Oh, there. Oh, I didn't know it was one of those.
Secret slides.
Oh, fancy slides. I don't do fancy that well. And then, and we've had increasing population in that area too. Then we want to improve water quality, and that's happened. 127 acres have been upgraded to approved. And then the percent of septic systems that are in compliance, again, in our marine recovery areas, our shellfish protection districts, that number is very high. In Nisqually right now, it's about 90%.
And that is a really high number if you look around Puget Sound. That's probably the best.
Yeah, we look at this every quarter and reassess, and it's been that high for a while now.
What's going on with you?
With the other 10%, how come they're not in compliance, or what happens where,
Right.
why they wouldn't get to compliance?
What happens with them? So depending on the severity, so there could be any number of reasons. There can be, they've discovered a problem and they're working on fixing it, but until it's fixed, we can't issue that operational certificate. So sometimes there's just that lag between, oh, we got a problem and now it's fixed. There's folks who, for whatever reason, just aren't doing what they're supposed to do. So we don't know what their system is, but since they're supposed to do it, that would be a non-conforming system. And yeah, those are the kind of the main reasons. There's something wrong, it's not getting fixed, or they just haven't done what they're supposed to do.
Thank you.
And then what happens depends on the severity of the situation and also the risk, where they're located relative to, again, public health risk. All right, next slide. So again, this is just a map showing, this is on the state health website, the shellfish website, showing where state health does their marine sampling stations, or all those little green boxes, and then where we've got issues. So the big red at the bottom is the Nisqually Wildlife Refuge, and we're talking with the state to see the areas that we're just never going to be able to harvest shellfish because it's a wildlife refuge. Can we turn that to some other color besides red? They did that for us in Woodard Bay because it looks bad.
But that red zone by where the Nisqually River discharges, where the wildlife refuge is, it's never going to be open for recreational or commercial shellfish harvesting. So.
And then the furthest north little red is a marina, Zittles Marina, and there's a mandatory closure zone around marinas. So again, we can probably never get that open. But those two little red blobs in the middle there, we're working real hard there to try to figure out what's going on. We've done some pollution investigations. It doesn't appear that we have septic, but it may be wildlife or something else. So we're working there. Okay, next one. And this again is we update these maps each quarter. The green shows who's in compliance with their operational certificate, parcel by parcel. The red is who's out of compliance. And then the yellow is considered vacant land, and the blue's on sewer. So again, we're doing pretty well. Next. Oh, that went 2,000. There we go. Just as a reminder, it's kind of obvious, but the reason that we don't want sewage getting into water or on the ground is there's a whole host of disease-causing organisms that you find in sewage, and they can make us sick. So I won't go into detail about what's in there, but trust me, there's a lot of bad stuff in there. Next. And so again, what the decisions we'll be bringing to you, and we're looking for your input, is what do we do next? The program sunsets the end of next year. So are we going to maintain the current program and go forward as is? Are we going to make some changes to it, perhaps incorporating more of the pollution and identification correction work, modify the dye trace requirements, combine it with Henderson, make some other adjustments? We're open to suggestions. So next step, I guess. Next slide. So the next steps, we can draft options and bring those to you. You can discuss it and tell us what you want to see. We'll look at getting some public input or health input, kind of going forward. And at the point where we need, let's just say that you want to continue the program or make changes, it will need to go to public hearings, and there's both Board of Health and Board of Commissioners steps required. So just know that there's a program. And then because we collect the fees through the property tax, rate and charge on the property taxes, we do need to have an answer by October at the very latest, so we have time to get the properties onto the tax rolls. Those deadlines. So that's it. Any other questions?
When I was reviewing this information, this seems like a very effective, obviously very effective program. I think if we're going to do public outreach or engagement, it would be useful to be able to demonstrate like a dollar value benefit that this has yielded for the community in terms of like commercial shellfish production or other benefits that can be measured, that we could say, we did this, and yes, it costs, homeowners and property owners money, but look at the stack of benefits that it has yielded for our community.
Dobbs Creek, is that what we're talking about?
That's over in Henderson.
That's the one next door.
So we've got this program in Nisqually and Henderson, and then nothing in Bud and Eld. Are those just healthier? No shellfish closures. They're all good to go. The problems have all been on the east side, or do they need the same program that these two have?
That would be a question. Some counties have opted to put all of their shellfish growing areas, whether they needed to be, put into a program. Well, how do I say that? So let me back up. Right now, Taunton and Eld have pretty good water quality, and the northern part of Bud has pretty good water quality for shellfish area. Eld, I would say, sometimes is declining, and sometimes it's always, it hasn't tripped over to have a downgrade yet, but sometimes it has threatened stations.
Yeah, if you go back in history, it did.
Yeah.
And what triggered these two is the shellfish downgrade. The good news is for Eld, Taunton, and Taunton, there have not been downgrades since 2001. If there was, we'd be talking to you about that.
Okay.
Yeah.
So they're just a little better.
Right, they're a little better. Again, some counties have opted to,
It's like Mason's pretty much covered
kind of
everything.
proactively put all of them into one shellfish protection district, and then they didn't have to have them coming in and out, starting and stopping, and simplify them.
But there's a
Does this affect like our drinking water as well, like that kind of health, or is it just shellfish, like saltwater?
Yeah, a lot of the same actions that it's designed for the shellfish, that protect the shellfish, also do protect the drinking water, which is groundwater. So if you have a leaking septic tank, you could impact the drinking water, especially if your well is not so far away.
Because I would think that would be something everybody could connect to. It's like,
Right,
oh, my
right. It's
drinking water is also.
The water connects.
Okay, well, that's great background for the decisions and
Great.
discussions for next year.
Thank you.
So let's.
Yeah.
And Kurt, I'm gonna look at you. We've got 2 more topics. We're gonna cover them both. They need to be done expeditiously. Is that possible?
We will go as expeditiously as possible. I know both need action required from the Board of Health.
Okay, well, let's move through it.
Okay. For the next one, we're going to talk about the opioid settlement overview and Thurston County opioid response plan presentation. Marianne O'Garo is going to lead off with this. And then on this one, one of the considerations we're going to request, staff is going to request to the Board of Health is to do a 1-year extension on the current opioid response plan. I'll turn it over to Marianne to start off with this.
Okay, thank you very much for your interest and concern about the opioid epidemic in Thurston County. My name is Marianne O'Garo, and I'm a senior epidemiologist with Thurston County Public Health and Social Services. And in speaking with you tonight, my role in that is someone who oversees the opioid response program And with that, I would like to also introduce to you Katie Strozik, our opioid response coordinator, and Kateri Wimsett, our education and outreach specialist who does naloxone training and prevention work with us. And then also we have a presenter tonight that's going to lead off, David Coe from Keller Williams, who's going to share a bit of the background about the settlement, a bit about the county litigation to provide you an update. And that is also thanks to Scott Cushing, who you see on the screen by name from the Thurston County Prosecuting thank you, Scott, Prosecuting Attorney's Office, who's arranged this for you. After Mr. Coe presents, we're going to talk a little bit more to make sure we've covered the opioid settlement information that you requested and wanted to better understand as we move into a very big year for both good use of that settlement money, good transparency about that settlement money and how it's being put to use for the residents of Thurston County, but also give you an update on behalf of the Opioid Response Task Force that you set in motion through your crisis declaration. Give you some highlights. I know we need to shorten it down because time has ticked on this evening, but we do really want to give you some good news and some highlights. We've included that in the presentation. And then just as was mentioned by Department Director Harden, we do have a request for your consideration for a motion that will really set us up for 2023 to be in a really good position for Thurston County. Both to respond to the changes in the epidemic that we're seeing and to respond to settlement funding. So with that, if it's okay, Mr. Coe, if I could turn that over, unless Scott, you have anything you would like to say, I would turn that right on over.
Nope. Just thank you to David for all of his work that he's done on this. It's been amazing and arduous. And many, many years. So we appreciate all the work that David and his firm has done for us. So I just wanted to say that. Thank you.
Thanks, Scott. I appreciate that. Nice to meet you all. Sorry, I'm on by telephone, so you'll just hear an ominous voice. Hopefully, it's not that bad. But I just want to emphasize what Mary Ann said. This is a really a momentous occasion for all of the nation and for all of the local governments that decided to pursue litigation against manufacturers, distributors, and also pharmacies of prescription opioids. As Scott mentioned, I myself and my firm, along with many other firms across the country, have been in the trenches litigating this case, and we are your outside counsel to Thurston County in this litigation, and we are also outside counsel to almost all of the litigating local governments in Washington State. I do want to note and commend Thurston County because they were actually one of the first, you all were one of the first counties in Washington State to decide to pursue litigation way back in 2017. John Tunheim agreed to pursue this case nearly 6 years ago, and that decision has led to, and obviously there have been other local governments to join, but that decision has really led to this case being resolved in large part both through this distributor settlement, which I'll talk about in a moment, but other settlements that will be down the pipeline and will provide much needed settlement amounts and revenue to the county and to all other local governments, both in this state and across the country. So on this PowerPoint in particular, and the numbers you see here, that is in reference to a settlement that was achieved with what we call the big three distributors, and that is AmerisourceBergen, Cardinal Health, and McKesson. So those are the three main distributors of not just prescription opioids, but some of you will probably be familiar with them because they are the three main distributors of all prescription drugs. In 2021, they reached a global settlement or intended to reach a global settlement with much of the country And it wasn't until just recently that the Washington AG decided to join in on that. I won't bore you with all the details, but it was the negotiations both with the distributors and with the Washington AG to get to where we are today was definitely, hard fought negotiations and lots and lots of meetings, Zoom meetings and in-person meetings with the Washington AG's office to try and get this resolved. The good news is that the Washington AG finally joined in what is being deemed and coined as this national settlement. And this national settlement amounts to approximately $21.5 billion that are being paid by these three distributors. The portion to Washington State is approximately $518 million. And the portion of that is going specifically to the local governments is about 215. And so I know that you all, like everyone else, are interested in the bottom line numbers. And the portion that is going to Thurston County is approximately 2.3% of about 215 million that's going to the local governments. That is being paid out over the course of 17 years, and the first payment actually will be made before the end of the year or shortly thereafter. I think it should be made on December 30th at this point. Those monies need to be used for opioid approved purposes. That is a strict condition on this settlement, and that will be a strict condition on any future settlements as well. And that makes sense, right? Because this settlement was always supposed to be to benefit the communities and to provide much needed remediation to communities to combat the opioid epidemic. So there will be, and I believe you all will have discussions about how this is actually going to be executed at the local level and at the regional level in Thurston County and adjacent and neighboring counties. But the bottom line is that there will be significant sums over the course of 17 years that will go to Thurston County. That exact amount varies from year to year, but like I said, it's approximately 2.3% of 215 million. So that, I think based on our initial estimates, there's a settlement administrator that's handling all these amounts. The exact amount, like I said, will be known when it's actually paid, but I think what it amounts to on an annual basis is approximately 250,000. Like I said, every year it's a little different, but that's what we're looking at on a directional level. I do want to emphasize that this is just one of the settlements. Obviously, it's a big one, but there are many, many, many defendants. There are manufacturers, other distributors, and pharmacy defendants that also either have settled, announced a settlement, or will be settling soon. Some of you may have seen in the news that the three main pharmacy defendants, CVS, Walgreens, and Walmart, have also decided to reach a global settlement. And those settlement funds will follow the same structure and allocation as this distributor deal. That settlement is roughly in the ballpark of 14 billion. So as these settlements continue to be inked, the amounts to all the local governments, including Thurston County, will continue to grow. So I just want to stress that this amount, while certainly not insignificant, is not the only relief that's coming Thurston County's way. There are also bankruptcies. Purdue, in many respects, the main culprit and the one who started manufacturing prescription opioids writ large back in the late 90s, they went bankrupt, as some of you may know. Excuse me, that bankruptcy allocation is still subject to appeal in the Second Circuit over in New York. But once that's resolved, there will be amounts flowing to local governments as a result of that bankruptcy. And there are a handful of other bankruptcies, including involving Mallinckrodt and Endo, that will also provide much needed relief to local governments. So I'll stop there. I'm happy to answer any questions about the details of the settlements or the litigation. But like Scott and Marianne mentioned, this is a case that's been going on for quite some time, and we're really happy and thrilled to see that there are actual monies now that are flowing through to local governments.
Questions for David?
I do have a question. Are individuals at all going to get compensated for the damage?
It's a good question. This case that Thurston County is involved in, and the MDL, which is short for multi-district litigation that is headquartered in Ohio, that's just an MDL involving local governments and other entities. Like, for example, tribes are involved. Some school districts have filed. But it's largely a non-individual case, so it does not involve individuals.
Sounds like we're good. David, thank you so much.
You're welcome.
Marianne, are you gonna grab the baton at this point?
Yes,
I can't
do.
see you up there, so, okay, good.
Okay, thank you so much. And so if we can go ahead and advance, I'll take you to, and if you go ahead, go to the next one, I'd appreciate it. So in terms of the settlement then, and one of the things just to hit on this particular slide, because I know this is of interest to people, just to know that this is coming down as part of the MOU that Thurston County signed, and that is to work with eventually, as part of receiving this money, we will be working with a 7-county opioid abatement council. So that is a group of individuals that are more like subject matter experts that will regionally convene with the purpose not of determining where the money goes, because that's determined by the MOU, what it could be spent on, but to ensure access to information to the public, a public-facing view of where the money is being spent, and that's part of the MOU, and to ensure that it's being spent on the approved uses. And so that is something that I know there was questions about this, but for you also just to think about, we have a lot of experience already, at least at public health and social services, and you do as well in other activities, working with the 7 counties involved. So Mason, Lewis, Pacific, Grace Harbor, Cowlitz, Wahkiakum, in doing other work, including substance use related things, tobacco, vaping, marijuana prevention, youth activities, a wide array of things that are conducive to being prepared to do this kind of work, working with CPAA and Choice. So we are in good stead to do this. But I will just draw your attention to that column of a portion of the money is going to go to the state and stay at the state. And that means we are potentially eligible to apply for that and however they choose to distribute that funding. So they'll be releasing opportunities for people to apply for funding within a range of areas that have been deemed priorities. So that's when it says specified funder. What I wanted you to know is that means they will be specifying when they release something, an RFP or RFA. You know, is it 1 year? Is it 2 years? Is it 3 years that you're applying for? They don't have the same requirement to have a council. We do as part of the MOU. When it says specified by funder under funding, you could be required, for example, to work with a specific partner or to go through a specific agency. That will be up to the state and how they choose to do that, just like it would in any other RFP kind of process that they would do. But it does connect to the state opioid plan, to their priorities, and we've been lucky. Both Katie and Kateri and others in Thurston County have been working hard to promote the interests of the task force and others in our community about what would be the priorities that would go forward for the use of that funding. So we've been doing that. And so I just wanted to share that with you. And the rest of the presentation is more about what's next. So I don't know if you have any other questions about the settlement.
Not hearing any. Let's move forward.
Okay. So, in being prepared for what's next and moving forward, you signed the MOU. We have a very active task force and work groups. We are very lucky with that. And we've identified gaps and strategies. And what we do need, though, is a local opioid response plan in place. And so with that, one of the things that we are asking is consideration tonight for moving the 2021-2022 plan forward. And I'd like to tell you a little bit about why that is and what our progress has been to date for that consideration. So if you go to the next slide, please. We've done and responded to the crisis resolution you put in place. We've convened the task force, we've adopted a plan, and then we revised the plan. And that plan was re-looked at the most recent task force meeting, and we had a discussion with them, and it was their recommendation that we move forward with the current plan with the current strategies. And if you could go to the next slide. That has 6 areas of focus, so very comprehensive, 26 strategies and 4 different aims. And that the reason being, because they seem to be fitting the needs and have the flexibility we need to move us through 2023, especially because we did have staff involved in looking at what are the settlement priorities, what does the MOU show, and at least puts us in good stead for that. And if you could go to the next slide, I appreciate it. And we have seen great task force progress. So we know things are working. We've been setting SMART objectives, achieving those. We've seen work in community and workplace overdose education and naloxone administration trainings. We've had great community response to Overdose Awareness Day. We've had amazing response from school districts. The majority of school districts have been working with us over this year to look at how we can help with overdose response and naloxone administration. Food establishments have been contacting us. All local law enforcement agencies have naloxone out of their own choice to be able to administer as needed. More government entities at the state capitol have been interested in being prepared to respond to an overdose. Our prevention campaigns are working well with our prevention work group. And just an example, we had an English and Spanish radio PSA campaign that was incredibly well received through particularly the Spanish radio stations. Community education panels, really helping people better understand evidence-based approaches, and the utilization of peers has worked really well. Regional and state partnerships have grown, including fentanyl fact-based education, where the University of Washington invited Katie as a subject matter expert to help them design a handout that is now used locally as well as statewide. And then again, working with the state in their work groups on settlement priorities. So we've had a lot of things, and so many community partners do things, which brings me to my next slide. And we really, because of in a very hard time, particularly as you know, and as you've shared your concern about fentanyl and how that is changing the face of drug overdose in Thurston County, we've still seen so much work done around trying to do what we can in the best way we can. We wanted to recognize those who are playing vital roles in moving the response plan forward, and the task force wanted to share with you that they identified a set of folks that have just done outstanding work in 2022. So many people have done work, but if you could go to the next one. Next slide, please. These folks are just some folks I really just wanted to draw attention to you. Some good news. Not always do we get good news in such a sad topic, really, one that affects so many families, friends, our neighbors, people we care about and work with. But the different work groups within the opioid task force identified these individuals and organizations as people who really contributed to the work. So we have a very active task force moving into 2023 with outstanding people. And this is just, the best of the best, and we have so many in Thurston County. So we wanted to share that with you. And in watching the time, I know the next slide, please. We are requesting and hoping you will consider a plan extension. And what that plan extension means is taking the 2021-2022 plan, extending it to the end of the calendar year. Here are some stated reasons, what we think it covers, some gaps that we're seeing. It allows us to focus on those, but at the same time in 2023, what we'd like to do is to take time as the settlement money begins, to really look at what a 2024-2025 plan really needs to look like, and also establish new SMART objectives, and then move forward from that point. And knowing what time it is, I don't know if you have other questions, but I will stop there.
I have a motion whenever you're ready, Chair.
Anybody have any concerns about the extension, proposed extension of the plan, or questions before they'd be comfortable acting? Okay, we're ready for that motion.
Okay, I would move to approve extending the Thurston County opioid response plans 2021 through 2022 through 2023 and authorize the Thurston County opioid response task force to continue implementation.
Second.
The motion has been made and seconded by Board Member Edwards to extend the opioid response plan for 1 year through 2023. Any further discussion?
I just want to thank Mary Ann for, and the rest of the staff members for all of their hard work on this. It's definitely needed in our community.
I guess as far as discussion, just real quick, you've all heard me talk about fentanyl and how serious that is, but you know, it seems like we put opioid at the top of the list, and a problem still is a problem, but it wasn't even near the problem that fentanyl is. If you talk about deaths and stuff, we're going to be over 150 deaths from fentanyl this year.
But fentanyl is an opioid, right? So you can use this funding to work on fentanyl.
It's an expanded version, if you want to call it that, you know. But we better start paying attention. That'll be my plug for that.
Okay, all in favor, say aye.
Aye.
Any opposed? That motion passes. Thank you, Mary Ann. Katie, anything you need to add to what we just covered and did?
Nope, I know that we're short on time, and I think Marianne did a great job covering it, and I thank you for extending the plans. We can work another year on it. I look forward to seeing the work we can do as the settlement money comes down as well.
Yeah, me too. I'm really excited about that. And this community's been out in front on that, and having that plan, I think, helps us. Okay, let's turn to our last item of business. Kurt, can this be handled expeditiously? I hope. I know it's got a time sensitive, or we would just move it, but this is Amendment 5 to the Lewis County contract for purchase of Nurse Family Partnership Health Services. This is a program that probably is more familiar to the board members than some of the other things we've covered. Gretchen Toller here. Gretchen, why don't you give us an idea of what we need to do?
So I guess I'll just preface it by saying, and County Manager Chavez, please tell me if I'm wrong, the reason this is coming before the Board of Health is it's for the purchase of health services with Lewis County, or Lewis County's purchasing from us. So my name is Gretchen Toller, the Maternal Child Health NFP Division Director with Public Health and Social Services. I'm seeking approval to our amendment number 5 to the Lewis County contract for the purchase of Nurse Family Partnership Health Services for the amount of $320,962, and this is for the period of January 1st of 2023 through December 31st of 2023. This funds community health nurses to continue serving 50 clients in Lewis County through the Nurse Family Partnership Program. And just one sentence about Nurse Family Partnership, for those who don't know, Nurse Family Partnership is an evidence-based home visiting program. We work with mothers to provide support, resources, and coaching to help families have the best outcomes over a period of 2.5 years.
And this is about Lewis County wanting to
Yes.
employ us basically to provide them service.
So in 2018, we developed a regional partnership with both Mason and Lewis County, so Thurston County being the hub. And so this is Lewis County purchasing Nurse Family Partnership services from us.
Any questions about this?
No questions, just a comment.
Yeah, go ahead.
Real quick, and I said this morning, we've been considered for many grants by DCYF because of this regional approach that we've taken with Mason and Lewis County. So just a great job, Gretchen, on this program.
Ready for a motion? Oh, go ahead, Board Member Vasquez.
I move that we approve the Amendment 5 to the Lewis County contract for the purchase of Nurse Family Partnership Health Services in the amount of $320,962 for calendar year 2023 and authorize the Director of Thurston County Public Health and Social Services to execute the amendment.
Second.
Motion's been made and seconded to approve Amendment 5 to the Lewis County contract. Any discussion? Call for the vote. All in favor, say aye.
Aye.
Any opposed? No. Okay.
Thank
Gretchen,
you.
got it.
Thank you.
Last item is Health Officer's Report. Dr. Abdulmalik, don't want to shortchange you, although there is a concert at Capitol High School at 7 o'clock with both my kids performing, but no pressure.
Good evening, Board of Health. I'm Dr. Daviana Abdulmalik. I'm the Thurston County Health Officer. I will keep it brief tonight. We are seeing a surge in viral respiratory illnesses in our county that mirrors a lot of what we're seeing throughout the state and throughout the country. I'll start with our COVID-19 numbers. So we're at 56.4 cases per 100,000 over the past 7 days, 126.8 cases per 100,000 over the last 14 days. Looking at our CDC data, which looks at the week ending on 12/10, we've had 4.2 hospitalizations of COVID-19 positive patients per 100,000 population for the week preceding 12/10. And at that point, COVID positive patients accounted for 4.8% of our inpatient beds and 4.7% of our ICU beds. So while our healthcare capacity is experiencing strain globally, for a number of reasons, including viral respiratory illnesses, COVID-19 is a piece of that, and we are overall seeing some of that transmission trends rise in our community. I did want to kind of share a little bit about the variants. BA.5 is currently 40.6% of samples that are sequenced in Washington State. This is down from well over 80% weeks ago. BQ.1.1 is accounting for 22.4%, and BQ.1 is accounting for 18.7%. So there's a little bit of a change in the specific variants that are circulating. However, we're not seeing a safety signal. So we haven't seen a significant spike in hospitalizations, and we haven't seen a significant spike in deaths, which is good news. The bivalent booster is available for kiddos 6 months through 5 years of age. And we continue to be able to act as a vaccine depot and support our community partners, as well as be able to provide that support to families in Thurston County as well. I did want to talk about influenza, which is looking a little bit challenging. So the data that I'm sharing is week 48. So that's the week ending 12/3. So transmission is very high in Washington State, and the dominant influenza strain that's circulating is influenza A. So some of what we look at are tests that get sequenced and reported. Some of the other data that we look at are kind of influenza-like illness, which is taken from medical records of folks seeking care through syndromic surveillance. And so influenza-like illness really accounted for 11.7% of visits for participants in the influenza like illness surveillance network in our state. So there's some groups that report what proportion of folks are being seen in this capacity. There have been 25 outbreaks of influenza-like illness in long-term care in Washington state, and unfortunately there have been 26 lab-confirmed influenza deaths in Washington state, including 2 in Thurston County, which is definitely a matter of concern. So, you know, in response to circulating COVID, circulating RSV, and circulating influenza, I and a number of other health officers did make a recommendation for folks to consider masking in indoor public spaces. Masking, you know, prevents spread of, you know, droplet-borne diseases like influenza and RSV, in addition to reducing the risk of spread for COVID-19. And we strongly recommend, you know, getting vaccinated for influenza and COVID, you know, for folks, you know, that haven't yet made it to their provider or pharmacy yet. In addition, you know, just wanting to, we're looking, you know, this is a time of year where we do see an increase in viral respiratory illness, and just want to make sure that folks at home, you know, who might be watching in our community really, you know, take care of yourself, stay home if you're sick, you know, wash your hands, cover your coughs, and as well as get vaccinated. And with that, I'm open to any questions or comments anyone may have.
Questions, comments?
I just ask real quick, does vaccination help prevent you from getting it or make your outcome less likely to be severe?
Are you talking about the COVID vaccine or
Yeah.
the flu?
COVID vaccine.
So
Well, or the flu, I guess I'd like the flu.
yeah, so really excellent question. So for the bivalent booster, we are, so COVID-19 right now, for folks that have had a primary series and have received a bivalent booster, which was targeted towards Omicron, which is what's circulating. So what we have circulating is Omicron subvariants. The new bivalent vaccine, some of the data that we've seen shows a benefit in terms of reducing infection, not like the infection reduction that we saw prior to Delta, but there's still some. But it prevents severe illness, so hospitalizations and deaths, and is extremely effective at that. The influenza vaccine, the CDC released that it's a good match for what's currently circulating. So this year, which is really good news, and it also reduces impacts from, you know, of severe outcomes from influenza. So I highly recommend that folks get vaccinated as well for that.
Okay, thank you, Dr. Abdulmalik. Any last comments for good of the order?
10 minutes.
I would just say that the next meeting is January 10th. It will occur at the new space, 3000 Pacific Avenue. And Kurt's, if you haven't heard, Kurt's long tenure as interim director of public health and social services is coming to an end. We've hired a public health director who starts December 27th. There'll be a month of transition, but hopefully David Bain is his name, and hopefully he'll be present at the next Board of Health meeting for everybody to get to know a little bit. So we're really excited about that. Okay, thank you, everybody. Sorry for the long agenda, but we had a lot to cover.
We made it.
Yep, we're adjourned.